their team. Party and conference include.
People can ask questions they may have about some of these methods. So the motivation for the use of methods based on inverse epoetin is that when we confounding, time-varying confounding methods to adjust for confounding, like stratification or propensity score matching or standard regression models, they all may yield biased effect estimates even if there's no residual confounding. So this is true even if we have measured all confounders, we may still have a problem. So I want to do is first to talk a little bit about this problem of conventional methods, and I use causal graphs to help me. Then I will talk about inverse IP weighting, and I explain very quickly why IP weighting solves this problem. Then I will talk about what are the data requirements that we have to be able to use IP weighting. And I finished by presenting some examples of research questions. I have 4 examples in different settings that I will very quickly describe so people can ask questions if we have questions later. So this is going to be a busy talk. I'm going to go relatively fast. If your questions are on the way, please ask. And if you wait until the end of the presentation, we will have time for more questions there. So the first thing that I'm going to do is to talk about the problem, the bias of standard methods. This is a causal graph. The people who are not used to using them, this just means that there are 3 variables, L, A, Y, and L causes A, and also causes Y, causes Y only. And this type of graphs, because they have a direction in the L causes A, but A doesn't. A causes L. They are called as directed acyclic because there are no cycles graphs, or DAGs for those of you who have seen them before. So we can use DAGs to represent a confounding. This is this that you are seeing there is a typical example of confounding. We have one exposure, and I'm going to use a very classical example. A is the exposure or the treatment of interest. In this case, is matches Y is lung cancer, and L is cigarette smoking. We say that is confounding because that is a common cause of cigarette matches and lung cancer. When it is confounding, then when A doesn't have an effect on Y, as in this case, we say that A and Y are associated. It should say there A does not have an effect on Y in the slide. Okay, this is the graphical representation of confounding, is the presence of common causes of treatment and the outcome. We adjust for confounding by conditioning on the confounders, and that is what that box there means. The box around the L means that we are adjusting for confounding by stratification or by adding the confounder to our model. In any case, it's a form of on the confounder. Once we condition on the confounder, then still A doesn't have an effect on Y, but we say that there is no association within levels of L. So this is what, say, a model does. We have a treatment A, and we add the confounder as a covariate to the model. Now we are estimating the effect of A within levels of L, and that eliminates the confounding by L. This method is the one that may not work when we have a time-varying treatment, and that's what I'm trying to explain now. So, situation in which the 2 variables, the treatment A and the outcome Y, they don't have a common cause. So there is no confounding, but there is a common effect. L now is a common effect. In this case, still A does not cause Y, and A is not associated with Y if this is happening, because 2 variables have a common effect, that doesn't make them associated, and that is a basic result from graph theory. If 2 variables have a common cause, they are associated. There is confounding. If 2 variables have a common effect, they are not. The problem is when the 2 variables have a common effect and we condition on the common effect. Example in graph theory is when A is the rain. Either it is raining or it's not raining. Y is a sprinkle system, either it's on or off, and L is the grass is wet. and the sprinkle system goes on or off every day at the same times, whether it is raining or not. So A doesn't cause Y. So it's not associated with Y. The sprinkle system is not associated with the rain, because if it tells you it's not raining, that doesn't give you any additional information to know whether the sprinkle system is on or off. And that's true if condition on the common effect of A and Y. If I look only at the times when the grass is wet, so I have a database with a lot of times, and for each time I know whether it is raining or not, whether the sprinkler system is on or off, and whether the grass is wet or not. If I now conduct my analysis only using the subset of my database when the grass is wet, and I tell you it is not raining, well, it's more likely that the sprinkler system is on. So by conditioning, by stratifying on the common effect of the two variables, we create an association between them. Okay. The point here is that A has no causal effect on Y. Whether it is raining or not does not affect the sprinkle system. But if you look only at the subset of times when the grass is wet, I will find an association. So because the section of observation, or only a subset of observations into my analysis, I'm finding an association, a bias that is known as bias. This bias due to selection. Okay. Now you would say, well, but we will never adjust for a variable that is a consequence of the outcome or that is affected by the treatment. Exactly what we do when we have time-varying treatments, time-varying confounders, and the confounders may happen after the treatment. So let me explain what I mean here. Okay? So first, the summary of what I said: two variables are associated when one causes the other, when they have common causes, that's confounding, or they have common effects, and we condition on the common effect. All methods that adjust for confounding based on a stratification or on conditioning make intrusive bias with the fact that they are adjusting for conditioning. The variable they are conditioning on is one common effect. It applies to all the conventional methods that we use all the time, mandatory methods, any standard regression models or Cox models or propensity stratification or matching. Okay, and the problem looks something like this. With a time-varying treatment, that's A0 and A1. Say that A0 is antiretroviral therapy, and A1 is antiretroviral therapy one after baseline. We want to estimate the effect of antiretroviral therapy over a year. We have on one outcome, that is Y2, say that outcome is death. And we have this variable L, which is our confounder. So L is CD4 count. CD4 count, L1 affects A1 because a CD4 count makes it more likely that the person will be treatment. And so L affects Y2 because a CD4 count means that you are more likely to die. One is a confounder. We have to adjust for L1. But at the same time, L1 is affected by prior treatment. So now, when we condition on L1, we have one first problem. The first problem is that by conditioning on L1, we are blocking the association between baseline treatment and the outcome. But by we adjusting for confounding, but we are adjusting for confounding by conditioning on L, we'll never be able to get the full effect of treatment because the effect that is mediated through L1 is lost. So that's problem number one. When we standard methods to adjust for confounding, we lose part of the effect of the treatment. All the effect goes through the confounders, or the treatment is lost. The second problem that we have is the selection bias that I was talking about. Now let's look at U. So U is a variable that I haven't measured. I don't have any information on U, but I know that it exists. Say that U is the immunological status of the patient and affects both the CD4 count, L1, and the risk of death, Y2. So we have a common cause of the initiation and the outcome within pharmacoepidemiology is almost always, like here. Now, if I add L1 to my model, if I condition on L1, I have a very similar situation to the one I described before when I had the rain at 0 and the sprinkle, that's 2, and the grass is wet, that's 1. If I condition on L1, I am going to create an association between 0 and U because I'm conditioning on a common effect. So by adjusting for confounding, because I do adjust for confounding because L1 is a confounder for A1, adjusting for confounding for A1, I'm creating bias for A0. I'm finding an association between A0 and U, and therefore between A0 and Y2, even if 0 doesn't cause Y2. That is the second problem that we have with standard methods, that we create bias by adjusting for confounding. So even if L1 were the only confounder here, there's no way we can get the right answer by adding it to the model because we are dealing with a time-varying treatment. Things get more complicated in practice because, of course, we don't have A0, L1, A1 only. We have A0, L1, A1, L2, A2, L3. We may have also an L0. So that's the problem, that if we use a standard method to adjust for confounding, when we have a time-varying treatment, then we will get bias. When there is a time-dependent risk factor, it's a determinant of future treatment. So with time-dependent confounder, also affected by prior treatment, and that is when standard methods will create bias. There is no way we can adjust for confounding without introducing this sort of selection bias when this situation. So that is the problem. We confounding if we don't adjust for the confounders, but we have selection bias if we do adjust for the confounders. We need all other methods. So that's the first part of the talk when I was trying to explain what the problem is. Now let's talk about one about the possible ways of dealing with this problem. There's methods that Robbins and others have developed since the late 80s that I'm showing here, and they're the only methods that are appropriate to adjust for this type of time-varying confounding. They are the formula, I-weighting, and G estimation. Those three methods that can be used in different flavors, depending on how many assumptions you want to make. These are the methods that can be used in this context. So here I'm going to talk about IP weighting of marginal structural models, which is a method that has been developed in the last 6-7 years, and that is now widely used in some parts of epidemiology, like in HIV epidemiology, and it's been used more and more in pharmacoepi and comparative effectiveness research. To describe IP weighting, which is a method to adjust for confounding without introducing the selection bias, I'm going to use a very simple example. In simplest example, IP weighting is the same as standardization. So you ever took an intro to epi course in which they tell you how to compute a standardized rate? Well, the same. That's actually what IP weighting does, except that IP weighting can be extended to more complex longitudinal data in which we have time-varying treatments and time-varying confounders. But the underlying idea is the same as a standardized rate. Let me give you an example. Say we have data. I don't want to worry about confidence intervals now. That's why I'm doing this. I will work confidence intervals later. Say that we want to make the effect of heart transplant A on death, Y, and we have a confounder L, which is whether the person is in critical condition or not. And this is the data that I have. You can by each number by 100,000 if we don't have to worry about confidence intervals here. And represent this data as a tree, as many people in decision analysis do. And this be the data from our study. So we have 800,000 people that are in non-critical condition. 8, but that's because I want to do all the zeros. Of 8, 4 receive a heart transplant, and 4 did. 4 who didn't receive a heart transplant, 1 died. Of the who did receive a heart transplant, 1 died. Okay, I've constructed this example in such a way that there is no effect of heart transplant. This is, of course, is that data. Okay, what we need to know here is what would be the risk if everyone had received a heart transplant. We have only these 4 people and these 9 people with a heart transplant. But what if everyone, including this and this, had also received a heart transplant? That's what IP weighting does. What IP weighting does is you can think of it as an imputation method or a simulation method, like all causal inference methods are, in which we are going to estimate what the risk of death would have been if everybody had received a heart transplant. We are also going to estimate the risk of death if no one had received a heart transplant, and then we're going to compare those 2 risks. So think about this. Let's first the risk if no one had received a heart transplant. If that were the case, that would mean that these 4 people here would have been up here. So in only 4 people in the part, I would have 8. Then rather than having 1 death here, I have 2 deaths. Similarly, in the lower part of the tree, right, these people would be here. So you have 12 people without heart transplant, right? 3, and then here also has to be multiplied times 4. So we have 8. That's exactly what the next slide shows, in which it shows you what we would have expected to see if everyone had been, if no one had received the treatment, heart transplant in this interest. 8 people, 2 deaths, 12 people, 8 deaths. Okay, we can play the same game to see what would have happened if everyone had received a heart transplant. And I'm going fast here, but it's going to be people who want to look at this at their own leisure time. So if one had been treated, then I would have 12 people here and 8 people there. Okay. Everything together, this tree is showing me what would have happened if all people, these 8 people had been untreated and been treated, and same for these 12 people. What I do here is I have now a pseudo population of 40 people rather than the 20 I started with. In this pseudo population of 40 people, everyone has been treated and everyone has been untreated. I have 20 and 20. 20 treated and 20 are treated, but they are the same people. So I can now compare the risk in the treated and the risk in the untreated, which in this case happens to be 0.5 and 0.5. The risk ratio is 1. So there's no effect of treatment. And this is all that there is to know about IP weighting, really. If you think about what I've done is when I had 4 people here, and I said, well, what if everyone had been here? What I'm doing is in each of the 4 people here a weight of 2, because the 4 people are going to represent 8. So I'm giving 8 of 2. But 2, this weight 2 is just 1 over probability of being treated. So what I'm by this little game is just I am upweighting every person by the inverse of their own probability of being treated. It's in here, and that's why the method is known as IP weighting. The base assumption for this method, this is how we represent the weights. They were 1 over the probability of receiving whatever treatment level you had, treated or untreated, on the confounders. For those who know what the propensity score is, this looks like the propensity score. And in fact, you can say that IP weighting is a propensity score method, because we're estimating the propensity score, but we are using it to weight rather than to match or to is stratified. There is one important thing to keep in mind, though, is that the method is that you assign to each person the inverse of the probability of the down treatment level. That if I am a treated person, you give me 1 over the propensity score as my weight. But an untreated person, you give me 1 over 1 minus the propensity score as my weight. So it has to be the inverse of the probability of treatment for the treated and the probability of no treatment for the untreated. The main advantage of this propensity score method, IP weighting, is that you can make it more general. You can use it for continuous exposure. You can use it for time-varying exposures, unlike the usual application of propensity score. The method is based on a big assumption. I'm going back here. When I'm telling you that what would happen if these people, if 4 people had been up here, right out here, and I'm using really these 4 people to represent what would happen if I had 8 people right down 4 people. When I'm doing that, what I'm assuming is that these 4 people that are pointed here and these 4 people are comparable, that they are the same type of people. That's known in epidemiology as the assumption of no confounding, or the assumption of no residual confounding given L. So all I'm saying here is that I believe that L is the only confounder. If that's true, this method is right. If that's not true, I have to keep branches to this tree until I make it true that the untreated and the treated are comparable within levels of all the confounders. So this method helps adjust for time-varying confounding, but it will give you a wrong estimate if this residual confounding. So it's not magic method. If we have confounding, we have confounding. There's nothing that we can do. Okay, so I'm doing this with a 2x2 table, but using a 2x2 table that is applied to the pseudo population, to the weighted population, we could, rather than that, fit a model to the weighted population. So we can fit the Cox model to the weighted population and compare and estimate the hazard ratio if everyone had been treated or not treated. The confounding adjustment is achieved through the weighting. This Cox model does not need to have any confounders as covariates. And that's the key part. The bias of conventional methods was due to adding the confounders as covariates in the model, or as to the conditioning on the confounders. If we have a method like IP weighting in which we adjust for the confounding through weighting, we don't have to put the confounders in the model. Then adjusting for confounding without introducing any other bias. That's how the method works. A method for confounding adjustment that makes it that has to adjust for confounding without having the confounders in the model. So a structural model is really estimated using a weighted model, a weighted model to estimate a marginal structural logistic model, a weighted Cox model to estimate a marginal structural Cox model. It's the same, except with weights. There is a pre-processing of the data in which we have to estimate the weights, same as when we use the propensity score analysis. There is a pre-processing of the data where we have to estimate the propensity score first. Okay. Then technical issue is that in practice we modify the weights a little bit for efficiency purposes. These weights that I show you, 1 over the probability of treatment, in practice receive very wide confidence intervals once you take into account the fact that the pseudo population is fake and we have only people and not 40. Then the confidence intervals are very wide. And in almost all applications where what you see would be this is stable weights in which the weights are multiplied by this factor, which is the probability of treatment without conditioning on the confounder. This is done only for efficiency purposes. It can affect the bias adjustment part which is saying that is achieved all by the denominator of the weights, and this is to get a confidence interval that is not as wide. And when we have time varying treatments, then we estimate the weights, we estimate time varying weights. The time 2, say here, is going to be the inverse of having the probability, inverse of the probability of having the treatment history that you had from baseline until time 2. So we have to estimate what is the probability of treatment at the first time and the probability of treatment at the second time, and multiply both, and that's the probability of having that particular history, and the weight is now has that product in the denominator. So the weights look something like this, where this symbol here means a product of time weights. That's why there is a tier, and they have in the product of the probability of treatment at time given the past treatment history and past confounder histories. That's how we have. That's how the weights are used in practice. But it's just a general version of a standardization. Really, we're going to end up with a standardized risk ratio or a standardized hazard ratio that we are doing with these weights, really. Okay. So that is a very quick view of what IP weighting is. My goal here is really not to explain the method in detail, just give you a flavor of what it is and try to convince you that it's nothing very complicated. It's very simple, and it can be applied using standard software. The information requirements, data, do we need to apply method? Well, we need a time-varying treatment. So we couldn't use this method with a case control study in which treatment is ascertained at one time only. We need to have treatment ascertained during the entire follow-up. We need to have the start date, the end date, the switch date. If there is a switch date, we need to know where the changes in those are, if that is relevant, etc. We also need time-varying data on the confounders, on the determinants of treatment over time. We are now about how this method can be used to adjust for non-compliance in a randomized trial. We can only use it if we have measures of the determinants of non-compliance during the trial, the time-varying determinants of non-compliance, or we cannot use it if we don't have information on the confounders. And then, of course, we need information on the outcome, which may or may not be time-varying outcome. It depends. We measure at the end of follow-up or earlier. Okay. In a sense, we need exactly the same data that we would need for any other method. We need data on the treatment or the exposure, the confounders, and the outcome. But if we're asking questions about time-varying treatments, then we need data on time-varying confounders too. IP weighting an advantage over the conventional methods because it can adjust for measure time-varying confounding with unbiased. This is what I was saying earlier. But I want to emphasize the measure part. IP weighting adjusts for measure confounding. If unmeasured confounding, there is nothing we can do. The method will be biased, like any other method in which we try to adjust for confounders, but we don't have the information. Okay. So let me now walk you quickly over a few examples of research questions in which the use of IP weighting of marginal structural models helps. First one is an observational cohort study. I'm going to talk about an observational cohort study, about a randomized trial, about claims data, and about electronic medical records data. I'm going to give you one example of each. So here we had this question: what is the effect of antiretroviral therapy on the mortality of HIV-infected patients? And we were doing this with the HIV causal collaboration, which is about 65,000 now HIV-infected individuals who have never used treatment before in Europe, and the US, and we wanted to estimate the effect of a time-varying treatment. Anti-therapy. People start treatment at different times and for different reasons, so there is time-varying confounding. And that is the challenge here, that we have a time-varying treatment and time-varying confounders that are themselves affected by prior treatment. So my CFR count now is different, is affected by what I've been on treatment in the past or not. So if we try to use, for these time-varying confounders using standard methods, we get answers that don't make sense, as I'm going to show you now. Say that the first thing that we do is to fit a Cox model for this treatment without adjustment for any confounding. The ratio, if we do that, is 1.4. Okay, biased. We are not trying to adjust for confounding, and there is a lot of confounding by indication for anti-retrotherapy. So this is clearly wrong. I'm showing it only for illustration purposes. Now, we add to this Cox model all the baseline confounders that we have here, everything that is measured at baseline. And by adding that, the ratio goes down to 0.8, which is better. Now, we still have a lot of confounding that we are not adjusting for, because there is a time-varying confound that happens after baseline. That is not included in the model yet. So we add that to the model, and what happens? The ratio is 0.8. So even though it is well known that there is a lot of time-varying confounding by indication, we don't get any benefit by adding all this to the model. What is going on? Well, we are adjusting for the time-varying confounding, but at the same time, we are introducing the selection bias that I was discussing at the start. So one essentially cancels out the other, and we end up in this particular case with the same answer. In other cases, we see cases in which the baseline adjustment is 0.8, and this is 0.9 or 1.1. In this case, it's not that, but we are not getting the full benefit of the adjustment. If we use IP weighting, we get 0.5. Okay, this is actually what you would expect to find based on randomized trials and sources of data. So this is an example in which we can show in an empirical way that the conventional adjustment for time-dependent confounding gives you a result that does not make sense because it is biased. So this I just saw how this is the adjusted the crude. This is adjusted for baseline, adjusted for time-varying covariates, and it's only when we adjust for time-varying covariates using IP weighting that we get to a reasonable estimate. The second example is a randomized trial, and in this example, we ask the question of what is the effect of continuous hormone therapy on the risk of breast cancer in postmenopausal women. Here we are using data from the Women's Health Initiative, which is a randomized clinical trial that collected information on determinants of adherence during the follow-up. So in this case, we can use IP weighting to adjust for non-adherence, and rather than only estimating an intention to treat effect, we can estimate the effect after adjustment for non-adherence. And in fact, in this case, we went further, and rather than only estimating a hazard ratio, we also estimating the curve if everyone had complied with their baseline treatment. Okay, and what we get here, so you can see here that the risk of breast cancer. I mean, this is the with breast cancer during the 8 years of follow-up. Now, in the group taking hormones, you have a lower survival than in the group not taking hormones. If everyone had complied with the assigned treatment at baseline. So these results are much stronger than the intention to treat results, because in this randomized trial, there was like a 40% non-compliance in one of the arms at 6 years. There are a lot of non-compliance. The ITT effect is very biased towards the null, and it's only by using IP weighting that we can get the effect after adjustment for non-compliance. The third example is based on a claims database. This is based on care. Here we wanted to compare the effect of different doses of chemotherapy on the mortality of patients undergoing hemodialysis. We had about 80,000 patients here, and we are using, as I said, the US RDS, which is part of the Medicare database too. And we again have the same problem. We have a treatment, EPO, that is given to these patients, but the dose of EPO depends on what their hemoglobin is. But their level of hemoglobin depends on whether on what their dose of EPO was in the past. So we again have this feedback loop between time-varying treatment and time-varying confounders that any standard method will not be able to deal with. And we used this method here to get the curves and different doses of EPO dose. And we found that they are very similar, that the total mortality doesn't change much by EPO dose. In contrast, a conventional analysis was finding a much stronger effect for high doses. Giving you all the references for this paper in case you want to take a look at them. And finally, in the example based on electronic medical records from the UK, from THEAM, we asked the question, what is the effect of statin therapy on CD risk? So a very simple question, just as a proof of concept that the method can be used here. We want to compare initiation of statin therapy versus no initiation of statin therapy. This paper will be out very soon. And here, what we did was to combine IP weighting with another method, which is the simulation of a sequence of trials. So to extract all the information in the data set, rather than only using IP weighting, what we do is to try to create a sequence of randomized trials of statin therapy initiation over the entire follow-up, and then use IP weighting. By doing this, we are really treating the observational data as a randomized trial, except for the fact that it's not randomized, of course. So we'll have to adjust for confounding because it is an observational study after all. But by conceptualizing observational study as a random trial, we can present a chart that would be the same that you could do for trial following the consort guidelines. And we can do everything following consort, except we are adjusting for confounding. So this is one alternative way of thinking about ways of presenting data from observational studies, is try to mimic the trial and present the same kind of information that you would present in the trial, plus the confounding adjustment. In fact, we can do an intention to treat analysis of a trial in which we compare initiation of hormotherapy with no initiation of hormotherapy, of statin therapy versus no initiation of statin therapy. If we just initiators with non-initiators, the hazard ratio is 1.4. If we compare, once we adjust all the confounders, the hazard ratio goes to 0.9. So you can think of this as a general version of the new user's design. A user's design compare initiators versus non-initiators of one treatment. Here we are doing that over time. So we are creating a sequence of new user designs in the observational data, which is more efficient. Now we can have the adherence to the baseline treatment in this observational study, same as you would look at this in a random, and we see that the adherence drops a lot for look at the non-inhibitors over time, over years. They start therapy at a high rate. So one of the 7 years, see, less than half of them are still not using therapy, and the initiators stop taking it also. So after 6 years, 30% of them are not taking it. So we have a lot of non-adherence. I mean, it's not much more than in the actual randomized trial that I described before. This makes the intention to treat estimates questionable. Same as a trial. So I'm because conceptualizing the observational study a trial, then I can use the same kind of thinking that I would use for a trial. And this is the intention to treat, but it's biased towards a null because I have a lot of non-adherence. And now when IP weighting comes into the picture, I can use IP weighting to adjust for non-adherence, same as we did in the trial before. And we can estimate the effect, and there are different ways of doing it. We see that the hazard ratio after adjustment for non-adherence is between 0.8 and 0.7 and 0.9, and there are different sensitivity analyses that we can do here. So to finish, IP weighting is an alternative to conventional adjustment for confounding that allows us to adjust time-varying confounders without bias, and also some side advantages, like the fact that we can now present a standardized curve rather than a hazard ratio. And if you think of this, if not most of the questions in comparative effectiveness research are about time-varying treatments. So this is a method that I think has a lot of fit here. Okay, these are some papers that some places where you can get more information about some of it that I was discussing here. And this is the end of my presentation, so I think that's for questions. Yeah.
Well, thank you very much, Miguel. Indeed, it was a great presentation, and I want to open this for questions. Any questions? Questions can be either submitted by typing them in this field there, or I think everybody is free to speak, right? Yeah. You should say. So while people are thinking about their questions, my question is, and I think I've probably asked this several times, but I will stop asking that. It's just works only as well as you can model the probability of treatment, right? And we struggle already with non-treatment at the initiation of your cohort of treatment, and it is my impression that it's getting even harder when people are already treated and then they switch to another treatment or they discontinue. What's your practical experience? How well are we doing in predicting this non-adherence or switch?
Right. So if you want to do just an intention to treat, then you only need to estimate the probability of initiation.
Sure.
And that's simpler than if you want to do a full analysis in which you have to estimate the probability of discontinuation or of switching. In some cases, we have decided not to go for the full because we don't have enough information on why people are switching, why people are discontinuing. We kind of know why people are initiating if we have measured the indications for treatment, but it's sometimes very hard to know that. In all cases where we have gone for the full analysis, what we do in practice is to estimate the probability of treatment in two stages. First, we estimate the probability of initiation among those who are not on treatment, and then we estimate the probability of discontinuation among those who are on treatment. There is no way of knowing whether we are getting it right or not. It's the same as if we put the confounders in the model, the outcome, we have no way of knowing whether we have model misspecification or not. So this potential model misspecification is not a new problem of this method. We are just shifting the problem from the model for the outcome to the model for the treatment.
Yep. Great. Right. We have a question or several questions. If Liz can read them, please.
We have a question from the audience. With observational data where clinic visits are not scheduled as in a trial, how do you define time units? Do you assume monthly visits, for example, or can you use changes in therapy as the unit to update covariates?
This is a very important practical question. That's why I was showing examples not only with observational data or with trials in which we have measurements at the same intervals, but with clinical data in which measurements come when they come. So what we do to deal with this is we used a time unit that's short enough that we don't have multiple measurements at that time. So, for example, for the HIV data, or actually for most of the clinical data, a month works as a time unit. So we have to do some data management to put all the data in terms of person months. So for each person and each month of follow-up, we know the measurements that were conducting that month, say of LDL, if we are looking at statins, and we also have the treatment for that month, whether it was started or, and we just carry forward for the months where we don't have measurements. And there is no bias in doing that. There's no bias because if there is no measurement, that means that doctors don't have any new clinical information. So the decisions were based on anything that we are missing. That doesn't create any problem with confounding. In some cases, a month may be too long if there are multiple measurements in 1 month and you want to use all of them. Then you could create a data set in terms of days. It would be huge. And we've never found a situation where that really helps. But month works fine. That answer the question, Brian?
That's extremely helpful. Thank you.
Okay. Okay. I'm seeing one question here. I don't know if everybody can see it. That says, in which situation we can conclude the causal effect association using MSM? It's really the same as with any other method. Using observational data, we will never know whether we are really estimating the causal effect because of the possibility of residual confounding. So if we have residual confounding, the method would be best like any other method.
So this is Sebastian again. Just a comment from the Decide Method Center with regard to the proposals that we reviewed. And the issues that Miguel is describing, I mean, they come up very specifically in some of the applications, but they come up in pretty much all of the proposals in a sense of when you study long-term effects. When your follow-up is anything longer than, I don't know, a month or so, then the issue of informative non-adherence, informative dropout, will come in one way or another, right? And we have to think of how do we want to mitigate this potential for time-varying confounding. And what Miguel has presented so brilliantly today, of course, is the method to go. And so we will hope to see more of these applications than in the research. Questions?
Yeah. Can you hear me?
Go ahead. Yes, I hear you.
Back to what Miguel just said about the time, there's no visits and that there's no new information. I'm not convinced it's true. You go to the doctor, you get some blood done. Number no visit, there might be a phone call, unless recorded. You get your blood done. In your case, the CD4 was fine. They say, okay, come back when you were supposed to come back. The CD4 wasn't fine, then there's a new visit.
Right, and that differential monitoring of people with different factors or with different measurements, that is very important because in a couple of studies that the pattern of observation actually matters. It's not they're seen more often because say your C4 counts low or anything. So that is something that can be incorporated into the method in which we adjust not only for C4 count or viral load, but we can also adjust for something you are being seen or what was the last time that you were seeing, etc., which may be a proxy for things that are not measured. If there are things that are really not measured and we don't have a proxy for them, then that is nothing we can do. In that case, yes, we will have confounding. The reason why I showed the study example is we did that on purpose. We were looking for a case with extreme confounding by indication. And in the study example, whether you give a person statins or not, that's a hugely confounded issue because, of course, you give statins to people who need them. And in that case, we see that if we don't adjust for anything, the hazard ratio is like 1.5 or 1.6, or is huge. There is a lot of confounding. And the point there was that even cases with a lot of confounding, if you use the appropriate method to adjust for whatever measure confounders you have, you can still find a hint of a benefit. I mean, the hazard ratio was 0.89 or 0.9 or something. So clearly, we were not getting the full benefit of statins that we know from trials. So we were getting a hint of a benefit, and once we adjusted for non-compliance, it went down to 0.7. So even very confounded cases, we can do better than just a conventional method. And just for the in that same when we use the current users versus never users type of comparison, the hazard ratio was 3. I mean, we were off. We were getting it. Now, in many comparative effectiveness applications, we don't compare initiating statins with nothing. That is an extreme case of confounding by indication. Usually, comparing things like initiating treatment A with treatment B, and I would argue that the not of confounding. For example, if you are comparing one statin with a different one, it would be less than for things like treatment versus not treatment or things like that. So I think that there is hope that observational studies, when we have high quality data over time, can get at least in the right direction in many cases. Of course, there is no way that is going to happen.
More questions?
I see a question at the chat that you want.
Why don't you read it? Because I don't.
Okay. So could you discuss methods of handling violations of the positivity assumption? For example, we have a covariate which influences probability of treatment to moderate degree up to a value of that covariate. But when the covariate is above that value, the treatment assignment becomes nearly deterministic. So the issue of positivity, for people who are not familiar with the method, the IP weighting of marginal structural methods, you can only use it if there are treated and untreated people in all levels of the confounders. You have some combination of levels of the confounders where everyone is treated or everyone is untreated. Then the method cannot be used because there is no one to compare with in that level. And then we say that there is no positivity because the probability of treatment is 0, is not positive. Of no treatment. When that happens, we cannot use the method. So you have a covariate that predicts treatment perfectly, and that covariate is a confounder. Then the only way ahead is not adjusting for that covariate, which of course leaves some confounding and measure, and they are biased. But what's important to notice also is that covariate has to be a confounder. If the covariate is not a confounder, even if it predicts treatment very well, we don't want to adjust for it. And this is and this applies to any propensity score method. Propensity score model is not the model that best is able to treatment the best. That's not the goal of a propensity score model. The propensity score model is the model that predicts treatments based on the confounders and risk factors for the outcome, for efficiency. But we don't want to have variables in the propensity score model that predict treatment only. Those variables create bias. So the positive problem only happens when the variable is a confounder. If it's a confounder, if it is a variable that is a strong determinant of treatment but has no confounding effect, then we are fine. It is not a positivity issue. That's what I want to say. Yeah.
So this is a line check from UAB. I have one question. So what if the probability you're getting is 0 or essentially 0, and you cannot do the inverse probability weighting? I mean, if there's some patient in your population get the probability essentially 0, what are you going to do? Are you going to exclude this patient, or?
There are two possible situations. One is when we have a 0, a perfect 0, and then there's nothing we can do. We cannot use that variable. Another one is when we have something that is close to 0. So if we have a probability close to 0, the inverse of that is going to be a very high number. It could be 1,000 or 10,000 or 100,000. That means that that person is going to be upweighted by 100,000, and that person is going to have a huge influence in our analysis. So in those cases, what people do is to truncate the weights. So something that we will see later when we have a case in which there is a probability of treatment close to 0, which is going to be a huge weight, people set some maximum for the weights. I'm not going to use any weights greater than 20 or 50 or 100, or I'm going to treat all the weights beyond the percentile 99. I'm going to set them to whatever value the percentile 99 is. That is not going to affect for confounding much, but it's going to protect us from the bias, from the sample bias that those close to 0 create. So in practice, you will always see that the weights are treated to very high values, like 100 or 20 or 50, and your estimates will not be sensitive to that quasi non-positivity problem.
All right. We're approaching the hour. Are there any more questions?
Dr. Hernan, can we ask one quick question?
Sure.
It's up on the chat board. It's from one of the people in our group. The question is, how do you decide the length of the drug usage cut points in your last example? So basically, are you only using clinical information, or are you also basing some of your information on the survival hazard ratio?
So this is the therapy, right?
The last example.
Yeah. Okay. So here, what we should do is to say, okay, what is the trial that we mimic? And in this case, we mimic a trial in which people were always. And I'm going to go back so we can see. I think I know what the question was inside from. We said I don't know this per protocol analysis, which is what would have happened if everyone had always been fully compliant with the baseline therapy, whether that was statin or no statins. So there is no period of time here. Is what if everyone during the entire duration of the study, which I don't remember how many years it was on average, say 5 years or 6 years, and this is the hazard ratio. What we did also was us treated use a very different model in which we compared 2 years of use versus no use. Because we chose 2 years here because the average time of use in our data was 2 years. I think that is the reason why we chose that number. But we could have used 3 years or 5 years, so we can show all of them, because once we have the model ready, these comparisons can be done very quickly. So it's really a matter of what is interesting from a subject matter point of view. Here we chose 2, but it's a better number that doctors want to know. Then we could have done that.
Thank you very much, Miguel, for this fantastic presentation, and thank you very much to our audience, and we hope to speak to you again in a month about it.
Okay.
Thank you, Miguel.
Thank you. Bye.